leukocytes to roll of the endothelium. This leads to the blockage of blood vessels and an increase in vascular permeability and damage to vessel walls. Doxium has anti-inflammatory properties and is believed to help inhibit the processes that lead to leukocyte adhesion, endothelial dysfunction and vascular permeability in CVI. Healthy endothelium regulates platelet aggregation, coagulation, fibrinolysis and vascular tone. This function is impaired in CVI. By promoting nitric oxide synthase activity and inhibiting endothelin-1, Doxium may play a role in restoring endothelial-dependent vasodilation. Doxium has also been shown to reduce blood viscosity and platelet aggregation, improving blood flow. Vascular endothelial growth factor causes vasodilation and increases vascular permeability. Doxium inhibits VEGF expression and downstream pathways, thereby suppressing vascular leakage, helping to maintain the integrity of the microvascular system. Doxium action on several biochemical pathways can in turn affect fluid and lymph flow, reducing edema. Doxium acts through multiple mechanisms of action to disrupt the pathogenesis of CVI, significantly improving the clinical manifestations of the condition.
MENA Pharm is an industry-leading pharmaceuticals company with a proud heritage of over half a century of experience in delivering cutting-edge technologies to produce the highest quality medicines. MENA Pharm is breaking boundaries and challenging industry norms in the pursuit of excellence. To fulfill this purpose, a clear vision of future expansion has come to fruition through multiple alliances and partnerships with specialized companies around the world.
We at MENA Pharm established the first research community in Egypt and the Middle East. Our team is composed out of young, talented Egyptian scientists and European experts. Together, we develop high-quality and cost-effective genetically engineered drugs.
MENA Pharm's Egyptian biotech subsidiary has enabled the introduction of a portfolio of complex genetically engineered medicines which compete with large pharma products. Its German subsidiary, Probiogen, is a global provider of intelligent proprietary technologies for the biotech industry at large.
There is substantial evidence that a new age is dawning for Egypt to offer exceptional opportunities, and MENA Pharm is perfectly positioned to ride into the future with life-saving and life-enhancing, innovative and yet affordable products.
Striking the balance between innovative and affordable medicines is the mantra at the company's core, allowing MENA Pharm to play an important social role by responding to the complex challenges of unmet medical needs of emerging countries. MENA Pharm's desire to overcome these challenges helps the dreams of the next generation to be fulfilled.
Doxium is a venoactive drug to treat the clinical signs of chronic venous insufficiency. Triggered by venous hypertension in the legs, CVI describes a severe form of venous disease. CVI is characterized by abnormal blood flow in the legs, which leads to vascular changes such as valve dysfunction and capillary leakage, and ultimately may cause symptoms such as swelling, pain, and ulceration. CVI pathogenesis is complex and multifactorial. Doxium is believed to interfere with a number of biochemical pathways involved in its progression. Chronic venous hypertension in the legs can lead to blood stasis, causing valve and vein distortion as well as inflammation. Increased pressure also induces low shear stress, causing leukocytes to roll and stick to the endothelium. This leads to the blockage of blood vessels and an increase in vascular permeability and damage to vessel walls. Doxium has anti-inflammatory properties and is believed to help inhibit the processes that lead to leukocyte adhesion, endothelial dysfunction, and vascular permeability in CVI. Healthy endothelium regulates platelet aggregation, coagulation, fibrinolysis, and vascular tone. This function is impaired in CVI. By promoting nitric oxide synthase activity and inhibiting endothelin-1, Doxium may play a role in restoring endothelial-dependent vasodilation. Doxium has also been shown to reduce blood viscosity and platelet aggregation, improving blood flow. Vascular endothelial growth factor causes vasodilation and increases vascular permeability. Doxium inhibits VEGF expression and downstream pathways, thereby suppressing vascular leakage, helping to maintain the integrity of the microvascular system. Doxium action on several biochemical pathways can in turn affect fluid and lymph flow, reducing edema. Doxium acts through multiple mechanisms of action to disrupt the pathogenesis of CVI, significantly improving the clinical manifestations of the condition.
My dear vascular colleague, good morning, good afternoon, and good evening, whenever you are in the world. I'm very happy today that we are going to present a live case with one of the most expert in the field. He is very well known for his research, his paper, his technique, and he is a very dear friend of mine. And he will show us not an easy case, not a simple case, but a very difficult case. My dearest Professor Victor Canata, he is the president of the venous and lymphatic diseases in Paraguay University. He also is very influential and speaker in a lot of venous congresses all over the world. The last one is Frank Beeth in New York, where he presented an exquisite collection of lectures. Professor Victor Canata is very well known for his technique, and he used so many modalities, and it's really a pleasure to have him as a faculty in our live cases from Paraguay. So let me first introduce Professor Victor Canata. You are very much welcome to MINAFARM Scientific Committee to invite you to show us your place of doing intervention, your life case, and also how you do the procedure live. And I will be collecting all the questions that come to us. We are delighted to have you, and the mic is yours, Professor Victor Canata. I can't hear your voice. This is Victor Canata room of intervention. It's a lovely place. You can see the duplex machine. Oh yes, now we can hear you, yes.
Now you're seeing my, nice to see you, Omar. Thanks for that.
Yes, nice to see you, Victor.
Okay, we are trying to figure out all the situation and everything. The final idea when we just start talking about what we're supposed to do and what we're doing it is just to show my clinic and see how we will work in Paraguay and to improve the way that we treat in varicose vein disease or patients. And the idea is I will just have to introduce part of my team. If you see here is my head nurse. She is Gladys. I will just do, okay. She is in charge of everything in my clinic. She's the soul of my clinic. She's taking care of everything, and she's working with me for more than 18 years already. It's a little bit of time. Then, if you saw behind me here, there is another of my nurses. She's Victoria. She's been training by me in sonography, and she will take care of what is going on in the sono area when we do the procedure. And if you saw here, the one who is holding the camera right now is my third nurse. She is Leticia.
Excellent.
I'm located in a in a medical building, we will go through what I have here as an office setting.
Yes, eager to know your office setting.
Leticia will, okay. This is inside of the office. Outside of the office, you will see the waiting area. It's a large waiting area with so many people sitting outside, as well as because it's a medical building, they have like 3 lounges when you will be able just to sit and wait for the doctor. Anyway, in my settings, I have 3 same places that I can book and see the patient at the same time. The patient are coming for the 2 different doors, and then you will come to one of the rooms, as you see here.
Yes, because of the net connection, of course, and he's moving inside the closed space. I apologize for any delay in the image.
Kind of devices. They have 1 or 2 lasers. They have a sonogram machine. Anyway, it might slow this is one of the rooms.
We're eagerly to see your room. Yes, we can see the head view now, which is the main room, but I don't think this is the room that you are in at the moment. So you have one shop service for varicose vein. Is that right, Victor?
Yes. We have like 3 places where we can see. We will just restore the communication because sometimes it's going down the communication. But as you see here, everything, all the settings are here. There are 3 different lasers. This is a 1470. This is a 1064. This is a 980, and this is a sono machine.
Yes. So it's very interesting that you have 3 lasers. Can you tell us quickly each laser machine do you use for what?
Patients are coming from Luminar 1470. This is came from Argentina. This is 1064 from, and that one, the third one, 1980, is coming from Argentina too. You have to remember that we have a great advertisement from Argentina, and it's more easy to get the machines from Argentina to us.
Okay. So this is, you call it what? A laser therapy room?
Yes, this is one of the lasers. I have the same setting in each one. Que corten todas las conexiones. Okay, great. This is one of the rooms. In the second room, I have the same settings and the same laser stuff. If you saw here, I will go to the third one. This is see, hold on 1 minute because I have to, the images is going down slowly. The same stuff that you saw in the other place is coming to the.
So this is the second room that you are in at the moment, yes? And what this room contains?
Hold on 1 minute to get the good view and to make sure that you are seeing everything.
Yes, now we can see you very well. I can see a very nice bed. Yes, explain what you have.
Let me show you again. This is another sono machine with the same stuff. There is a monitor and an EKG machine in all the rooms, as also there is another laser machine. This is one that I'm trying right now. That one is from China. It's a very good machine that I always suggest for all our
Yes.
because it's a very cheap machine. It's not expensive like a both side 18,980 at the same in the same machine, and it can be using with all the fibers that you wanted. You can use with
This
a
is,
radial. You can
yes.
use with the and also you can add the pen to do spider veins if you want to
Excellent. So this
do.
is dual head laser machine from China. Okay. I'm very sorry for the delay. I have to apologize. The delay in the image because he's moving inside the closed space. But as you have seen, he has a nice laser machine from China, which we can see recently they are adapting a lot of laser technology. Yes, you can speak, Victor. I'm very sorry, the voice, we can't hear your voice at the moment because you are in a closed room. Maybe if you go outside will be better. Now you back to the reception area. We can't hear your voice. We can't hear your voice at the moment, maybe because you are away from the mic. We'll try to sort out the sound problem. I apologize dearly for that, but we are inside Victor Kanata therapy unit. You can see we have seen two of his rooms. Each one have duplex machine, laser machine. Yes. Yes, Victor. Yes, we can hear you now. Please go ahead.
Que me puede hacer así, porque de hacer así cambiar todo. Igual no podemos hacer nada, dejarle ese ahí.
We can hear you now, Victor. I think you're speaking Spanish.
Are you listening much better right now?
Yes. Oh, yes. We can hear you very well now. Yes, continue, please.
Okay, great. I will put that back in again. Oh,
Okay.
okay,
Yes.
great. You have
Back
to
to
be a little
reception.
bit patient because you have to know that we are broadcasting all over the world, and sometimes the Wi-Fi is moving.
It's gone again. We can't hear you, Victor, I think because the sound signal from the room is. Oh, now I can hear you.
Okay, great. This is the laser that I recommend for.
Yes, this is the laser from China.
Yeah, because this is no more than $8,000. This is affordable. It's not like the angiodynamics or Elphoton that is more than 45,000. This is impossible for a young guy to buy it.
Okay.
But this one is a very good one. The settings are very nice. You will be doing very good laser ablation without big trouble, meaning that this is the one that you have to go for it.
Excellent.
Sometimes if you have a company or if you have a hospital who will buy everything, okay, just go for the angio stuff or for the Elphoton stuff. But from my point of view, that one is working very nice without big trouble. Then
Yeah, but
this is
the machine, does it has CE mark or FDA approval or not yet?
they have FDA approval already. Yes.
Excellent. Excellent. Very good. That's a good information.
Then there is the third room up here, who have the same equipment that you saw before. They
Yes.
have the setting, they have a sound machine, everything. And we prepare right now just to do an easy case, not a complicated one, with the Flebogrif case.
Excellent.
To finish with this room and all the stuff, if you see here, you know, you can see me in front of everything, and my rooms are behind me, meaning that I will be able just to see 3 patients at the same time. This is the idea.
Excellent. That's the idea.
Maybe one sclera in one room, in the other one, maybe I see a wound, or in the third one, I saw a lady with the first consultation with some kind of new problem, or maybe I will be doing a sonogram.
Excellent. That's
Are there
fantastic.
any questions regarding about anything? Do you have any questions?
At the moment, there is a question that which laser machine do you like for superficial telangiectasia? What wavelengths do you prefer?
980 work very nice in the face. They are working very nice, but there is no way to have very good results in large telangiectasia in the leg. But for teeny ones, you will be able just to do it with that machine, that the Chinese machine is working very nice without big trouble. This is my special corner with everything. As you see here, I have this, my Egyptian awards. Okay, this is part of my, I have that for so many years already, and this is part of my life. Okay, anyway, I will start moving forward and try to show you the lady that we will do today. First, I will just to see she's lie down already. We will do in 3 steps. In the first steps, I will show you the case. In the second one, I will just dress myself, and then I will show how we prepare the Flebogrif, and then we will try to do the case. Okay?
Excellent. Yes. Do you like to have the PowerPoint presentation of the case?
Yes, you can start showing me the PowerPoint presentation of the case.
Okay. So we're going to start now the PowerPoint presentation for this particular case that is being done live from Paraguay. Yes, here is the slides. We can see the first slide. If you like to comment, Victor.
This is a 51-year-old female with no past medical history. She has already varicose vein ulcer ×2.
Yes.
She has, as you saw at the right, in the right picture, there is a large bulging veins that she was seeing so many physicians and so many doctors, and everybody is afraid to do this case because the veins are very bulging and the sono is very tricky. So far, if you saw, the duplex sono show the incompetent saphenofemoral vein from the start from the joint on ground zero at the union with the femoral vein to 5 centimeters below. In mid-tide, they reconnect and again and come back. If you see the bulging vein is the anterior saphenous vein, meaning the reflux in the long saphenous vein start and again below the knee where the anterior saphenous vein discharge. Then the long saphenous vein is dilated with refluxing from a perforatum at the knee level, and then the vein is completely dilated from the knee to the ankle. Can we see the other slides, please?
Do you want here is the next slide.
Yeah. Okay, this is almost the picture of what's going on in the sonogram. In the sonogram, if you see over there, you will see the iliac vein, the common femoral vein, the femoral vein, and then the saphenous vein. The long saphenous vein have like a 2 or 3 centimeter refluxing area. Then the anterior saphenous vein, suck all the blood from there, and it gives like 2 centimeters more of dilation of the long saphenous vein. Then the vein get shrink very small, and then as I told you before, there were a perforator near to the mid-thigh, and then reappearing again with a refluxing vein at the level of the knee going down to the ankle. This is that we have, and this is the case that you have today here. Next slide, please.
Here is the video.
There is the video showing where she has already the ulcer. Then you see a lot of epiphyseal vein, bulging veins, that all of them are coming from the saphenous vein and from collateral that the patient have it already. Do we have any questions?
Yes, we have a question about the medication that you give these patients before you start.
Okay. All the patients, before any treatment that I have, I give it to them some venotonic agent to improve the way that the patient feels, to go down with the pain and also with the edema. I usually use Doxium. That is a good drug.
Calcium doxylate, that's right?
Calcium doxylate, 500 milligrams twice or 3 times in a day for the full time that the patient will be prepared for the treatment. And then after the treatment, when she has already the treatment done in my office, and the results are great because the pain was already released, they feel much better, and the results after the treatment are really excellent. Can we see the next slides, please?
Next slide is the video, and that is all the slides that we have.
Great, great.
So you give medication before you start, and I heard calcium doxylate in Paraguay is called Doxium as well. Is that right?
Yeah, it's the same one. Yes.
Excellent. That's fantastic. And this is preferred venotonic. Okay, now we know the case, and I thank you for a difficult case, not an easy case. And tell us your thought and how your strategy to tackle this patient in one stage.
Okay, I will show you right now. Can we switch to the short camera view?
Yes.
Okay. I just demarcate everything on her. Put the second camera on
drawing. So tell us what you do with the drawing. You put red arrow.
Let me show you. Yeah, there are a lot of stuff up here, but I would like to clear up everything. You saw here, this is the long saphenous vein up here with the refluxing area of 3 to 5 centimeters from the union to the femoral vein. And then this is the anterior femoral, and this you will see all the veins that are going down up here. Okay, so far, if you saw here, it's just the saphenous vein that is already
occluded. We can't hear.
Will see.
Please? Oh, yes, now we can hear you. Yes.
Yeah, we will see what's happening in a few minutes. Okay, so far, so good. If you saw
it's
here,
excellent, yes.
I will start just to show you. This is 10, 20. The black marks are the centimeter from the knee, from the groin to the knee, just to start doing the Flebogrif case.
Okay, so the red arrow is every 10 centimeters.
No. The black one. 1, 10, 20, 30, 40, 50, 60, 70.
Okay.
The red arrows are the place where I will do a full phone ablation. What I mean with that, I will just do the Flebogrif, and then I will attach 1 avocat at 10 centimeter, one avocat over here, another one up here, another one up here, another one. You see, the red ones are the places when the patient will have the avocat. Then, after I put the avocat inside, I will start I will start trying to do access the vein, trying to pass through with the Flebogrif, and then I will put 1, 2, 3, 4, 6, 7, 8 avocats to add more foam to these large bulging veins that we have over here. And this will be the idea. I will add and give to the patient more than 30 or 40 cc of foam. And you will see that she will be doing all the procedure without big trouble. Any question that we have from now?
Yes, I have a question. What type of monitoring do you put your patient on? Do you have pulse oximetry or a way
I mostrar el monitor. There is just pulse oximetry, just to check that everything is okay, and meaning that she is without big trouble. Look at her. Hola, ¿cómo está, señora? ¿Te duele algo? Okay, I've been talking to her in Spanish right now. She is lying down, no medication, no problem at all, and she's waiting for our treatment. Any more questions that you have?
Yes, one small question regarding technique of foaming. Do you do compression to saphenofemoral junction or not? Obviously, we're going to see that.
You will see everything.
Excellent.
Give me a minute. Okay?
Okay.
Great.
All yours. You can start.
Okay, let me change myself. 1 minute, and then okay. I will start dressing.
Yes, we're progressing very well, and we have a lot of attendee on YouTube and following our channel, plus around, I think about 70 or 80 already live all over the world to see your procedure. So eager to tell us all the tips and tricks, Victor. You scrubbed very quickly.
Yeah, we'll be doing it. Don't worry.
Okay. This is a Flebogrif tool, which he will explain to us, which he found in two sizes of cast, 60 centimeter and 90 centimeter. It's a beautiful device, which was idea of German phlebologist. And we'll see how it is used, because there is a lot of tips and tricks in how to use the Flebogrif. And he will explain to us, Victor, all the steps to how to inject the foam.
Mostrar el catéter, Lady, por favor, mientras tanto. Mostrar el catéter de Flebogrif. I will speak Spanish sometime. I'm sorry about it.
That's all right. Yes, we know that you speak Spanish fluently. No problem. We need to have your picture again, por favor. Obviously, he's going to scrub. He's going to put the camera to tell us where exactly is he looking at, how he do foam, how he use Flebogrif. It's very exciting procedure, very exciting technique from one of the mastering of this procedure.
Bloqueado porque la computadora. Bloqueado. Entonces no te maneja. Okay. No te preocupes. Can you just?
Yes, we can see. And we can hear as well.
Okay. Are you seeing what is going on already? This is a 90 centimeter catheter of Flebogrif. Ponele ahí, Leti, mostrar el catéter un ratito. Sí, hacer nomás. Un balón chiquito. Poquito nomás, Leti. Victoria. Okay.
Yes, that's it. Brilliant. Now we got a very good view of.
Okay, you see the Flebogrif?
Yes, we can see Flebogrif.
Okay.
Yes.
This is the settings are the avocats. This is 18 gauge avocats. This is 27 gauge needle. This is 30 gauge needle, 21, and a lot of covers just to do the trimming. This is only saline. That one are 0.5% of polydocanol that I will do for the collateral and the epiphyseals as a foam. I will foam with this. It will be like a 20 to 30 cc of foam that I will make with this one. Then
Yes.
this is the 3% of polydocanol that I will just use when I will start doing the procedure with the Flebogrif. Now I will open the Flebogrif. Any questions? This is a 90 centimeter catheter of Flebogrif.
Yes, if the camera is looking at the catheter, maybe a little bit downward,
Yeah,
the catheter will be
catheter.
Yeah, brilliant. Now, we have a question here regarding
Yes.
foam. You did
Yes.
mention to us that there are machines that makes foam and there is pre-foam cartridges. What is your strategy for foam?
No, I have very good foam without machines, and I have very good results without. I have so many machines in my office. I don't want to get more machines, you know. Since
Yes.
I've been doing it really great with the Cesari. I usually use only Cesari for everything.
Excellent. That's a very good lesson. Thanks, Victor.
This is the Flebogrif setting. It's a very special setting. If you see here, the Flebogrif settings came everything inside. I open up and you will see the needle. This is the principal needle. Then after the needle, you will see two 5 cc syringe. And after the two 5 cc syringe, you will see the introducer with the, I think it's a 5 French.
Yes, this is very
look.
How you prepare the Flebogrif. So look at Professor Victor, how he do it.
Okay, this is
5 French cheese.
The three-way stock up to do the foam. We will just keep moving. This is our needle, and this is the catheter. I will prepare right now the catheter, and this is the introducer for the catheter after the puncture. Okay?
Yes.
Okay, I will just open up the catheter. If you see, the kit is very nice done, and they have everything that you require for a very good treatment.
Yes.
Then you see the full length of the catheter. The full length of the catheter is a 90 centimeter catheter. If you see from here to the other, you will see the demarcation of 10, 20, 30, 40, 50, until 90 centimeters. So far,
excellent.
I will show you how I prepare my catheter. Un poquito más
Yes.
cerca de ti. Look, I usually test everything, trying and make sure that it's not in trouble. You see here, I usually test just to make sure that it's not going out. Also, I check the tip to make sure that it's not, because sometimes the catheter fails, and I cannot fail, you know. If I leave something inside of the vein, will be not happy with the patient.
Yes.
Then, if you see here, the end has a lock.
Yes.
To leave us to open and down, and then with this one, you can fix not to release anything after you do anything.
Excellent.
And then you go back and forth with the catheter as much as you require. After I do that, I clean the catheter with saline, making sure that the saline
There's no air.
Yeah, it's no air.
Yeah.
I clean already the catheter. The catheter is clean. Then I use at 5 cc to seal out everything. And in the
Yes.
second one, I do the same. I get some water, some saline. We'll just any question that you have from the
Yes, I have a question.
Great.
Is Flebogrif catheter painful? That's one question.
You will see the patient is awake. She doesn't have any medication, and you will see what's going on already. You will check by
Exactly.
yourself.
Yeah. Excellent.
Okay, I will erase the other part of the catheter and make sure that everything is okay. Now I have the catheter and everything okay.
Excellent. So this
Then,
can basically do abrasion to the intima of the vein. Is that right?
yes, that's right.
Okay.
I will erase my introducer, give some water too, make sure that the introducer is okay.
Yeah.
This is something that usually has to be done to make sure that all your treatments are okay, and you make sure that I work in an office when I cannot fail, meaning that the patient has to go home 100% of them.
Excellent.
And this is the idea. I've been working on this for more than 25 years with the ablation and all the stuff. Now, I think we are moving forward to the foam. Foam is the key for everything.
Excellent. Okay. Now we have seen the preparation of the Flebogrif catheter, which is available in Egypt and many countries in the Middle East. Basically, the technique depends on causing abrasion to the intima of the vein and then injecting foam. So it doesn't work only by abrasion, it doesn't work only by foam, it's a combination. That's why it's pharmacomechanical. So there is a mechanical element and pharmacological element. It's a very nice catheter, to be used. And we will see the technique that Professor Victor Kanata is using. As we all know, there is a lot of machine that makes foam, but in his experience, just injection by the hand is good enough. There is also
the SARI technique is good enough.
Yes,
the SARI is the one that I use.
The SARI technique is the oldest technique by Tessari, Italian phlebologist, and we still use it up till now. And with Victor Kanata 25-year experience in foam, you can't beat this record. So we are with you now, Victor. You can continue.
Yes, yes, please. Put the other foam. All right.
Excellent. Next, we can see you. We can see the duplex machine. And
you will see the Doppler. We will start going up and down with the lights and everything to make sure that we are able just to do the puncture of the vein. Okay.
Yes. Yes. Okay.
Look, this is the. Give me a minute because we will switch the.
Oh, that's a huge vein.
Yeah, this is our vein. This is the long saphenous vein. We will try to go through this vein for the patient. Victoria, sacate. Todavía queda ahí, Victoria. Okay. Okay. Look how is the vein bulging. Okay.
Yes.
We will try to just go up here. Look, you see?
Yes.
Okay. Great. Okay. Any questions?
Yes, there is a question. Which puncture do you prefer to do, it transverse section or longitudinal section from your experience?
I do the best for me always has been in the long section, because in the long section I'm able always to see the full length of the vein as well as the full length of the vein. You see up here, I just moving from one side to the other.
Yes, you see, he transverse the vein into longitudinal view by rotating his probe, and you can see he's very experienced in doing that. He brings the image exactly in the middle, and then he put the
Abre la
needle
luz, Victoria.
LS.
Ataja ese gallo. Okay. Okay. Te vamos a pinchar un poquito, señora. The patient is awake. You have to remember that.
Okay, it's good. You can see the needle. It's moving slowly into the
Okay,
anterior
Victoria.
wall of the vein. You can see it very, very nice view. Thanks, Victor. You can see how well controlled his needle, his view, all done single-handed. Is done beautiful.
Give us 1 minute to go.
So LS view is a preferred view by Professor Victor, and all the experiences
Look how is
ufologists do it
the
LS.
vein are coming. Okay. Give us a minute because
That's all right. That's all right.
to
Take
make
your
sure
time.
that
And I'm keeping hold of the questions that is coming until you're ready. No problem. This step, he must have full control. He usually give local anesthesia, and you can see the needle beautifully in the screen. In the middle, you can see how well controlled he's moving the needle into the anterior wall of the vein, progressing gently, progressing slowly. You can see the shaft of the needle clearly. You can actually see the bevel of the needle. It doesn't need to be GPS guided needle. There are now, of course, a lot of machines have needle tracking software, which can help, but with experienced hands, you probably don't need it, and you can puncture as small vein as you can. And this is a nice machine, Sonosite. Sonosite give very good image, sufficient what you do. You can see how he's well controlling the image, well controlling the needle, is doing the puncture. This part of the procedure, you need to have a concentration. You need to make sure that you have punctured one wall, not double puncture. And that is why you need a full concentration. You need patient to be cooperative, not to be mobile. Maybe a little bit of sedation would help with the local anesthesia. And this is called office procedure. You don't need to go to theater to do it. And definitely all the new era is endovascular, from a small puncture into the vein. You can do what surgical procedure has been done in the past, but I'm keeping hold of a lot of questions for Professor Victor. Yeah, after he finishes critical stage of the procedure. One of the tips and tricks, so when you have multiple puncture, then the vein goes into spasm. So you either go to another area to select another puncture area, or you maybe give a little bit of local anesthetic warmth, and maybe you can
dilate the vein a little bit more. This is the area, as you said.
Yeah. You have to be very accurate in this step, because once you put your sheath inside the vein and make sure that it is the vein, nothing else, it's a critical step that has to be done methodically, have to be done calmly, as you have seen on the image. And now he's getting the vein in LS view, and then they get the needle in parallel into the duplex with an angle little bit more than 45. You can see it's very well controlled. Even with a small vein, you can easily puncture it, and then you can push the wire, and even you can see the wire with the duplex machine once you have this full control. Sometimes this step takes a little bit of time to secure.
There is already, the wire is already in the saphenous vein, you see?
Yes, we can see.
Okay.
Yeah.
The vein is already cannulated without big trouble. I will just put the introducer right now and make sure that everything is okay. Give me just a minute.
Yeah, no problem.
I will change my view to just give some of my nurses to rest a little bit. Can you put the other camera in, please? The air camera.
Yeah.
If there is any questions.
Yes, we have a question that
Yes.
why do you
Yes.
Yes, the question is, why do you choose Flebogrif and not surgery for this patient? I think a question coming from vascular surgeon. I think maybe he's changing the camera, so I will just grab this question quickly. All the recent advances in phlebology mention that if you have minimal access, you're getting less complication. And according to NICE guidelines, the number one recommendation to treat varicose vein is endovenous laser ablation. Is number one, not surgery.
Can we switch to the other camera when you will see us working?
Yes, I can see your screen now. Yes, you can see you working. Yes.
I want the other camera in, not the one with the sono, the one with the full picture of the.
No, the one we are seeing now. Oh yes, we got another
the
one
other
from
camera.
Yes, the whole camera. Let me see if we are able to get the whole camera in view. Okay, we're going to shift now to the camera in the ceiling of the operating room. But we are watching your duplex machine at the moment, and we're trying to shift to the operating theater, the main room, because this one will show us how you're moving with the caster. Much better. So there is a question until we shift the camera. A question: why do you prefer Flebogrif over
because it's
avulsions?
The question is because the patient. Do you see the patient is awake with no problem at all, just not putting you in trouble at all. You are able just to do everything without problem. The only thing that is just a little bit tricky is just to get the access. Let's see if we were able just to get the access of the case, because this is a difficult case, as I told you before.
Yes, it is very difficult case. That's true. That's why
let's keep moving forward.
Okay, we're trying to shift the camera to the overview camera. It's just taking a while, little bit.
I have the Flebogrif here with me. I will try to. There are people who go with the.
Now we can see both cameras in our screen. The overview camera, and we can see the duplex camera. Both of them, we can see them.
Okay.
So now you
Now will
secured
be
the
the
5 French sheaths into the vein.
yes.
Okay.
Let me see. I will just start trying to go just with the Flebogrif inside and see what's happened.
Okay. He's passing the caster. You can see from the ankle upwards. And it was very tortuous vein, so this step is not easy at all because there was a lot of tortuosity into the vein and maybe a lot of areas of old phlebitis as well.
Yeah, because he has twice already the
Yeah. And this will cause plenty of vein synecdoche and web inside the vein, which make this step to be difficult, not easy.
Bueno,
You can see how Professor Victor is doing it nicely.
ponerme más blanco, está muy lejos para mí. No veo yo. Y sí, pero rato. Pero otro lugar donde veía. Okay.
Yes, okay. We can see he's pushing the caster with his right hand, and his left hand is the duplex. He's following the caster with the duplex. Once the
Sí,
caster goes in, yes, the vein goes into spasm.
Enfrente mío, Víctor, no vale estar acá. Y no me interesa. ¿Qué debate eso? ¿Cómo se llama? No. ¿Qué haga así? Mover su curso, ¿verdad? Que mueva su bebé. Ahí. Ay, muy bien.
Yes, this is a perforator, isn't it?
Yeah, it's a perforator, but I will just to get the access over here because the catheter is not going through over there in the other place.
Yes.
Give us a minute, we will do it again. If you're unable just to get the access of the first time, the idea is just to make sure that you have another choice to have the access again. And this is the second area that I will just try to have the access, you see?
Yes, I can see. Yes, looks very nice.
Yeah. But usually because those patients has a lot of phlebitis and a lot of infection in the leg, the catheter is going through the many perforators of the patients, and
Yes.
sometimes you are unable just to do the full treatment.
Yes.
And sometimes happen that stuff. Ponele a ese de que ahí nunca ayudamos. Déjala esa ahí. Una punción, un pinchazo, señora. Más completa, denme, por favor. Más ahí. Sentir un poquito que te tocamos. Ya sé, sí, mamita, pero cuando te tocamos te va a molestar nomás un poquito. Eso, en cambio, si estoy bien adentro, ¿no?
This is a very nice setup. So you have one nurse taking charge of the anesthesia to the patient, and one taking the foam, and one for the duplex, and you. That's a very nice setup. This is your usual setup, Victor?
Yeah, this is the way that I usually work.
That's excellent.
Any question that we have from the audience?
Yes, I have a question. How long is the recovery from Flebogrif? Do you give them a stocking or not? And how long does it?
We usually put stockings for short time, not too much. 1 or 2 weeks because the weather up here is very hot.
Okay.
Uh,
So 1 is 2 weeks. Yeah, that's very good. Yeah, that's a rapid
the other
recovery.
question?
Yes. Do you ask your patient to wear stocking after this procedure, or no need for stocking? Graduated compression stocking, is it needed after Flebogrif and foam?
Guys. Yes, I usually let them to wear it for 2 weeks, but then, you know, the weather up here is very hot and the people complain about everything. Moverle de ahí, sácalo.
Okay. If there is any of the attendee who would like to ask their questions themselves, they can ask for permission to have voice and we can unmute them. But if you write
Any
it down,
questions?
chat, yeah.
Vamos mirando porque si puedo llegar hasta recibir la tarde.
Yes, we have a question. Is
Yes.
50 centimeter of foam is your maximum dose in
No, I
some?
will give it to them a lot. I will use a lot.
Yes.
More than 40 I will use. Yeah, they will see it, you know. The patient
Okay.
is awake. ¿Te duele, señora? ¿Ve? You have to know that the patient is with me right now. Okay, ahí está ya.
Okay.
Okay. Look, I just cannulate the vein. I went through the okay. I went to from the structure.
Yes.
Look, if you see here is the wire inside
Yes.
of the area when we have the structure. Do you see the blue marking? Can you move? Let me move acá. Ese es acá, ¿verdad?
Yes, yes, we can see the caster.
Okay, and this is, we went through from the mid-thigh, and if you see here, there is a white dot. You see the white dot? This is the wire that is
Yes.
already in. Okay, I will
Yes.
try to go through the catheter right now. This is the saphenous. I will show you the saphenofemoral junction.
Excellent.
We will try to. Great. Any questions?
Yes, we have a question. Is there any age limitation for Flebogrif procedure?
Bryce, andate allá al fondo porque tengo que pasar con la salí ahí, venía acá. Okay. There is no age for anything else.
Yeah,
And there is
it can
no
be done.
problem.
Ages. Yes, there is no age
It can
limitation.
be done. It depends of everything. If I choose this difficult case, because I did earlier easy one, acá la even could be on.
Yeah, we appreciate that this is difficult case, and actually
Because
we let
there are questions regarding about how much will be the amount of foam, and we will see this in a minute, and then I will pull the catheter through the vein.
yes.
Avísame cuando sale la vida. Ahí estoy afuera.
So now your caster is reaching to saphenofemoral junction, is that right?
Yeah, I'm near to the saphenofemoral junction, but I have to negotiate 2 or 3 areas.
Yes.
You remember the structure that we have around here?
Yes. We appreciate that this is very difficult negotiation, not easy. Someone would think that larger vein is easier to pass inside, but actually it is very difficult due to tortuosity and the large diameter and the previous phlebitis. So we appreciate that you are bringing us a very challenging case of C5 with a previous venous ulcer. So this is not an easy case. It's a difficult case, and it shows a lot of tricks. It's very important to know where exactly is saphenofemoral junction and where you are, because if you are inside the common femoral vein, then there is a problem, a big problem, because you create iatrogenic DVT. That is why you can see Professor Victor taking his time to pinpoint exactly.
Any questions?
Yes, we have a question here about the success rate of Flebogrif. What is the success?
There is a more than 90% of success rate of Flebogrif. There is a very nice catheter, and you will be able to use without big trouble.
Yes, and I got another question from John Garrigas. He said it is applicable if there is a total occlusion of distal 1/3 of the anterior tibial artery. I think he means vein, not artery, because all the procedure we're doing is just in veins. So he mentioned that, is it applicable if you have part of great saphenous vein occluded? Can you still do Flebogrif?
If the what? What was the question? Sorry.
It's all right. If part of the great saphenous vein is occluded, as in this case, can you still Flebogrif?
I have already, as we spoke before, the vein has a full structure from here to here, meaning that we will just, if you see the mark over here, let me mostrar un poco la marca. Between 30 centimeters from, meaning that the catheter is already up to here. That is the area that we have the dilation.
Yes.
And that will be enough, because that one has a full structure, meaning that we will just get over here just with the foam. We will do Flebogrif from here to here, and in the other we'll do just foam. Okay?
Excellent. Yes. Excellent. That's a very nice explanation. So,
moving forward.
Yes.
Any questions from the audience?
Yes, there is a question. When the hooks of the Flebogrif are being deployed, do you deploy it all the way or halfway, or what?
No, you will see that the catheter has a mark, as I told you before, and I show you. Look.
Yes.
There is a dot, a black dot here. Do you see it?
Yes. Yes, I can see the black dot. Yes.
The black dot shows that all the hooks are inside of the catheter.
Inside the catheter, yes.
When I will release and I will push that down. When I push that down, all the hooks are going out, and you will see the hooks working on the vein. Look, right now is the place where the mid-thigh, look, I'm moving right now where the hooks are already in, between 30 to 40 centimeters. This are the area where the structure started, 40 centimeters at the mid-thigh. Okay?
Yes, okay, yes, you can see it very well.
Any questions?
Yeah, let me check.
Fine. I will start doing the second part, as I told you. Yes, a vou oxigenar. Vai venir comigo. Sim, a vou oxigenar aqui e compressor.
Yes, we got a question here. an advantage of using tumescent
Ponle título para que vos no te
anesthesia in this
canses.
case?
Andate al otro lado ya, ¿verdad, hijo? Hacele medio y medio. Okay. Now, just to remember, mostrame acá un poquitito, antes de que ponga. I'm here right now at 10 centimeters from the saphenofemoral junction that it has a full structure. From
Yes.
here to there, we will do the full Flebogrif. The catheter is in place, and you will see how the Flebogrifs work from here to here. Then
Yes.
I will start putting the catheters for the avocat, as I told you, just to make sure that all that epiphyseal is already down. Okay?
Excellent. Yes, okay.
Okay. You will have my sono and my room air right now. Poneme hacia acá Tu cámara, hacia acá Mira, muestra espectacular como trabajo. ¿Ya? Ok. Compresa la echarme en cantidad antes de venirlo. Bueno. Any questions?
Yes, there is a question. Is there an advantage of using tumescent anesthesia with Flebogrif?
Yeah, you can use tumescent anesthesia with Flebogrif after doing your after you put in your foam, you can add them, and the result are the veins collapse much better, and the foam acts much better over the area of the problem of the patient. Okay, necesito las tapitas, el agua.
There is someone want to have a question?
Yes.
And we are going to allow him to put the question himself. His name is Jose Javier Catilot. We will let him speak and put his question himself.
Ana Victoria, muy ¿qué será? Ayúdame, será, si no, no vamos a ir acá. Cinta. Poneme acá en los costados la cinta y yo voy a agarrar de acá. Any questions? Look, I start putting the avocads in the area where I just add the foam. Vamos, Victoria, préstame.
Okay.
The patient is fully awake. ¿Te duele algo, señora? Perfecto. Vas a sentir que te pinchamos, vamos, Victoria. Que te pinchamos un poco. Pero eso es normal, señora, por el tratamiento que te estamos haciendo, ¿ok?
We got a question about the glasses you're wearing. Is it a surgical loop, and which magnification? Is it 2 or 2.5?
5x. The magnification is 5x.
5x.
Yeah.
Oh, that's very good. So
Yeah.
it is a
I
magnifying
made
loop.
it prepare because my eyes are not as good, you know.
No, you're very good. But what do you use it for? 5-time magnification for the.
Yes, because sometimes I have to do sclerotherapy at the same time.
Okay, fine.
Okay, for these cases I don't require.
Yeah, oh,
But
that's
for
good.
there is some aesthetic cases that there are ladies who would like just to have
So
everything solved.
Professor Victor
you know,
is wearing a magnifying loops,
Yeah.
which magnify 5 times. And this is what he uses for spider telangiectasia with microcannulation, but not for the Flebogrif. But he has used to wear it all the time. He used to look inside it or outside it according to the procedure. But because this patient doesn't have microtelangiectasia, then he probably is using his normal eyes. You can see now this is very good.
I do something, I irrigate the catheter. I went inside,
Yeah.
I irrigate and put some tape just to make sure that everything is okay. You see?
Yes,
1, 2, I show you
see
how
with the
many
mobile,
catheters I will.
if we can change the angle of the mobile a little bit, it will show us
Yes.
exactly what is happening, and we can see a very nice
Mover un
couch
poquitito
below the knee.
el ángulo, Leti.
Okay, that's it. That's a beautiful view. Yes. Now you can see the operation from above and from the side. It's a very clear view what he's doing. You can see the needle, the puncture, and the injection of the foam, how the lower limb is slightly flexed and rotated outwards, and how he's having the assistant to prevent the blood flushing back, and then aspirate, and then inject. Yeah, here is another question. Is this patient have a primary varicose vein or secondary to all the DVT?
No, she doesn't have a DVT, but she has a primary varicose vein and so many infections. You have to know that those kind of patients that go to the hospital and they are seen for so many practitioners that they are very afraid to treat those patients. They say, no, if we operate those cases, it will be a mess. And this is a large case with a very difficult patient, and they keep asking for some stuff that the patient will never be able just to make it, you know. They ask for a OBGYN consult. They ask for a lot of stuff that at the end, she was behind 3 years trying to have the vein solved.
Yes. Yeah, that's a very good question. Very nice reply. And you can
You
see the
see,
whole
1,
procedure.
2, 3, I have already 1, 2, 3, 4, 5 axes already. I keep going and moving forward with the axis.
Excellent.
I irrigate after I.
You can see the strategy that Professor Victor Kanata is using, a nice combination of pharmacomechanical and pharmacological with the anatomy of the current varicose vein. He've used Flebogrif in certain areas and used foam in another area in a combination manner that in his hand, with a 25 experience, can solve the problem without surgical intervention. And you can see that he has given us one of, I wouldn't say an easy or intermediate case. This is very difficult, complicated case, and how he's smoothly doing it in a well-staged manner.
Any questions?
A very nice drawing. At the moment, no question. One question: during foam injection, do you do compression of the groin?
No, I will show you
Or
what
not
is going on
necessarily?
already in a minute, in 1 minute. Let them to be just patient regarding about how we do. We are right now getting access to all the areas that we require that we will add foam.
Okay. Yes, well, there is a question here. What is the maximum dose of foam that you're using? He said,
the guidelines say that you can use no more than 15 cc. We will use today more than 30 cc. Let them to be patient just to see what is going on. We are almost close to the. Había uno que marcamos acá atrás. ¿Dónde está? Ese. Ya estamos, señora. ¿Cómo estás? ¿Bien?
and I got another question: does this case can be done on 2 stages, or do you prefer to do it 1 stage?
Patients in my country want to do everything at the same time.
Okay.
Okay, you can book the patient and do like a 5 times if you want it, but if the patient will coming back, I don't know. Because sometimes those kind of patients, they get lost between 1 or 2 treatments.
Yeah. Maybe this is a question which is good for junior staff, which have seen you with your experience hand doing a lot of foam. When they start their practice, maybe they can start by staged procedure
They have
until
to start with by staging and not with
Exactly.
a difficult case and not too much foam. Then when they get enough practice, they will be able just to fix everything at the same way that I did, and I'm doing it right now.
Yeah. If any one of the candidates, a lot of candidates that we have live, if you want to ask your question yourself to Professor Victor Kanata, you can raise your hand and we will allow you to speak and to put your question with your own voice. So feel free, raise your hand, ask us a question. This is very important demo of how to treat varicose vein in the very recent advances with very experienced surgeon to very difficult cases. It's really unique experience that we are witnessing at the moment. We have seen the setup of the clinic, the pre-operative of the patient, the medication of getting venotonic calcium doxylate, pre-operative, intra and post-operative. And it's a great chance to ask all questions that you have in your mind to Professor Kanata. I got a question. Is there a maximum size limit of great saphenous vein for Flebogrif? Is it, do you think 15 millimeter?
No, I
or
use
14?
for more than 12, 13, or 14 centimeters already.
Yeah, so it can be used really to very large vein. And even if it is larger, you can put a bit of external compression. So that's why the hooks will do a bit of damage to the intima. So there is no really maximum size that you wouldn't say that you cannot do Flebogrif because of the larger size of the vein.
Really?
You can see how we do multiple cannulation in a staged manner according to his drawing and his pre-operative planning, how the patient is lying comfortable. I got a question here. Do you give anticoagulation to these patients like heparin before the operation or no need?
No, I never use, in my life for any patient. It's expensive. Can you put you in trouble? And I'm not using anticoagulation in any of my patients. I just have them been coming to my office very often and make sure that a patient is walking and deambulating and making sure that the results are good and my treatment is really good. This is my stage and this is the way that I've been working.
Yeah. I got a question here from a colleague mentioned, do you do any courses for foam sclerotherapy or Flebogrif that they can learn from it? Paraguay is around 6 hours by aeroplane from Egypt. So do you do any courses, Victor?
We do that, Doctor. Yes, we have a lot of the stuff, a full immersion of everything. We show everybody else how we do everything, and the people are very happy with all the treatment. We show them everything. We do foam, we do ablation, we do I was gonna. Sí, dígame. ¿Listo? Uno último nomás ya, señora, ya terminamos ya. Paciencia un poquito nomás.
You can see how low down he do the puncture just above the ulcer, and then He will put the needle in it, and usually the big vein near the ulcer is the one that if it is closed, the ulcer usually heal quickly. So you can see how he's done the puncture. The antiseptic solution, probably it's chlorhexidine, antiseptic.
I know I never use povidone iodine because they
Yeah, it give brown color as well, and
it give a brown color, and also I lose the small details that usually have. Okay, we have already 100% of the cannulation. We will just go for the. Póneme la tapa ese al revés, que no estés para poder limpiar. No, el otro lado. ¿Cuál es el más fácil? Ese.
Now you will witness the foaming stage with this very difficult case. I think it's very, very important to watch and to learn how he do foaming. And hopefully he will tell us all the tips and tricks. What is a good foam? What is a bad foam? What is the ratio of air to polidecanol, and how he perform it, and what sequence. I'm really very, very thankful for such an opportunity to witness one of the very difficult cases that we face.
Okay, as we said before, we got our catheter. The first catheter is the principal one. Flebogrif is almost to the 40 centimeters from the saphenofemoral junction, meaning that the Flebogrif is around here right now. We will see ahora tengo que poner al revés, para que vean la pantalla. Ok, great. ¿Agua oxigenada? Y vamos a levantar la pierna arriba y comenzamos. Gladys, acércate acá para apretar. Poneme ese cepillo al lado y este no sirve de nada. Sí. Más poner eso que me siento todo que abajo, este también. Echar una completa para poder llevar la pierna y colocar abajo. Este blanco sí tenemos uno para colocar. There is any question for anybody else?
Yes, there is a question. There is an ongoing trial for the evaluation of long-term outcome of Flebogrif?
Yeah, I have already cases that have been done for more than 4 years, and I have like a complete closure in more than 90% of the cases. I'm very happy. Do you see the patient is quiet without big trouble? The breathing is 74 right now, saturation 98. ¿Te duele algo, señora? Look, she's saying no. She is awake. She will get the full treatment, and then she will go walking out from the office in 1 hour. No pain at all. You know what I'm saying? And this is the idea of the small and the less invasive treatment for the saphenofemoral vein, you know? I think this is the best approach when we just give less arm to our patients, the results are much better. I will elevate the leg right now, see?
Yeah.
We're
so
putting up
now
the
you
leg.
do
Look.
elevation.
Yes,
So
to
now the
inside
vein
the
are
vein.
empty. Yeah.
Yeah. Then I will prepare the foam.
Okay. They want to use the mobile screen to see a close look while you are injecting foam. We know that the duplex doesn't have much information now. We need to see the foam is injecting from the mobile screen. Is that possible?
Yes. Poder colocarle un poquitito más cerca. Están viendo yo el...
Yeah.
Sí.
So first step you can see now is elevation of the limb, and cannula is in place. And now he's preparing the foam. Hopefully, if we can see how
you
he
see, I
prepares the foam
have
as well.
over here, I have 2 cc. I will show you up here. Acá se nota.
Oh, yes, we can see. Yeah.
Okay. Let me.
Yeah.
Okay.
What percentage of air do you put?
I have 3% polydocanol.
Okay, brilliant.
Papá me dijo que tire todo.
So it's 1 to 4, and you
A
need
veces
to
hace el
look.
código, se va por el ecolite.
Yeah. Yeah, there is definitely ongoing trial. Flebogrif has been announced 2006, and it has so many studies between 100, 200 follow-up
Ahora
cases.
una compresa y se cautó, una
Up to
compresa
10
le.
years follow-up after Flebogrif paper is available over the internet. It's not a recent device. Good. So now he's taking air. There is some people take carbon dioxide, some people take air, a percentage 1 to 4, and then he do how many times he do, and he sees a consistency with the form. So watch Victor when he do foam. He's been using foam for 25 years. He's extremely experienced. Don't do your first case like this one. Have a good selection.
Yeah, because this
Start
is
little by little.
okay.
He's preparing the foam. Yeah, now we can see the foam. You can see this is the Sari technique. And you can see it immediately converted into foam.
Okay.
Yep.